Hello everyone, welcome back to Dr. Tristan Anaesthesia tutorials. It is Tuesday. I apologize for the delay. As I'm sure some of you saw on the various social medias, I had a wonderful weekend away with really the best group of friends that one could ask for. So we're a little bit late, but I've got, probably 3 or 4 hours of incredible content for you today on pediatric neuroanesthesia and scoliosis surgery. So before we get into the first talk on the approach to anesthesia for scoliosis surgery, I just wanted to take a couple of minutes just to thank my group of friends. They know who they are for an amazing weekend. For, male friendships are really important. All friendships are important, but social isolation amongst men is a huge problem. And, so find yourself a group of friends, keep them close, treat them well, and they'll look after you. And like I say, friends are the family that you choose. So thanks to those gents. And that's it. So first, before we get started, I just wanted to say a big thank you to our first official sponsor, Nova Anesthetic Practice Management. And here is a short message from them.
Nova Tech tools simplify every step of your anesthetic workflow. Start with Nova's digital pre-op assessment and consent forms, completed online before theater. Bill from your phone or tablet with a mobile app. Dictate your notes with an AI speech-to-text tool, then send a quick post-op satisfaction survey. Need a script? An electronic script app makes it fast and paperless. With Nova, your practice is smart, simple, and fully digital. Visit novaanesthetics.co.za to learn more.
All right, thanks again. Hello everyone, welcome back to Dr. Tristan Anaesthesia tutorials. It is Tuesday. I apologize for the delay. As I'm sure some of you saw on the various social medias, I had a wonderful weekend away with really the best group of friends that one could ask for. So we're a little bit late, but I've got, probably 3 or 4 hours of incredible content for you today on pediatric neuroanesthesia and scoliosis surgery. So before we get into the first talk on the approach to anesthesia for scoliosis surgery, I just wanted to take a couple of minutes just to thank my group of friends. They know who they are for an amazing weekend. For, male friendships are really important. All friendships are important, but social isolation amongst men is a huge problem. And, so find yourself a group of friends, keep them close, treat them well, and they'll look after you. And like I say, friends are the family that you choose. So thanks to those gents. And that's it. So first, before we get started, I just wanted to say a big thank you to our first official sponsor, Nova Anesthetic Practice Management. And here is a short message from them. All right, thanks again to Nova. If you have any questions, please contact them on their socials. They really will be able to take your practice to the next level. So guys, what are we going to talk about today? We're going to talk about my approach to the comprehensive anesthetic management of scoliosis surgery. So basically, I'm going to take you through optimizing patient safety, blood conservation measures, neuromonitoring, and post-operative care in children having complex spinal surgery. So as we say, this is Dr. Tristan Anaesthesia tutorials in our series on pediatric neuroanesthesia, and this is scoliosis surgery. Just remember guys, a disclaimer, this is not medical advice, this is not examination level educational advice. Please contact your local doctors, physicians, hospitals. Please contact your local professors, registrars, consultants, etc. This is intended separately from my practice as a specialist anaesthetist, and it's intended to educate both medical professionals, students, and the greater public. Please do not distribute this work without giving me the credit. I do not oppose you disseminating this at all, but please give credit where it is due. So now that that's out of the way, guys, let's get to our presentation. So what are we going to go through today? We're going to go through introduction to anesthesia for scoliosis surgery. We're going to talk about the pathophysiology of scoliosis. I'm going to talk to you about the Cobb angle. We're going to go through preoperative investigations. We're going to talk about patient counseling and important consent issues. We're going to talk about preoperative blood conservation. We're going to talk about the prone position. We're going to talk about postoperative visual loss, neuromonitoring, motor evoked and sensory evoked potentials, anesthetic considerations for neuromonitoring, and physiological effects affecting neuromonitoring. Then we're going to talk about controlled hypotension in order to minimize blood loss. We're going to talk about the drugs used, risks and side effects. We're going to speak about tranexamic acid, blood conservation techniques intra-op. We're going to talk about post-operative blood conservation, analgesia, pain management. We're going to discuss post-operative complications. And then we're going to just talk a little bit about a multidisciplinary team coordination. And then we'll go through our conclusion and key takeaways. So guys, what is anesthesia for scoliosis surgery? Scoliosis surgery is complex, all right? So there's often extensive spinal corrections. It can be multiple levels. It can span both the thoracic and the lumbar vertebra. And it's often in pediatric patients and most commonly in early adolescence. So obviously, anesthesia plays a key role in optimizing our surgical outcomes, and we can really make sure that the patient doesn't lose massive amounts of blood. What we can also do is to make sure that we ensure that the risks of the prone position, of postoperative visual loss, neurological injury and fallout, etc., we can really, with a thorough, comprehensive and really careful, measured anesthetic, we really can, improve these patients' outcomes spectacularly. And I always say, all my registrars at WITS will have heard me say this, I truly believe that an hour sort of oral exam on this that I'm about to teach you, in my humble opinion, is probably one of the best ways to assess whether a candidate is ready for their final exams. And personally, if I could set an oral exam, I would do it on this. We would spend an hour having a back and forth, letting me throw a million things at you. And if you can handle yourself with your approach, your structure, pre-op, intra-op, post-op, etc., I really think that it shows impressive Okay, so essentially the next issue is we play a critical role in patient safety, and we are there to ensure that the child, the patient, is safe from a blood loss point of view, from a positioning point of view, from a neuromonitoring point of view, etc. And we really need to be critically focused on maintaining spinal cord perfusion and function and reducing blood loss. Then we also mustn't forget that there is a critical role for multidisciplinary coordination in the anesthetic management, and this will include pediatricians, orthopedic or neurosurgeons. It will include pediatric ICU, critical care, physiotherapy, occupational therapy, dietitians, etc. So it really is a big a team effort to manage these kids safely, but it can be done, and it can be done really successfully. So what is the pathophysiology of scoliosis? Well, essentially, if we look at the most common causes, idiopathic adolescent scoliosis is by far the most common cause, and that's the one that we see most commonly and the one that we correct most commonly. You then need to be aware of congenital causes, and these are significant because they obviously present much earlier in life. They can be more severe, and they can come with other systemic or other organ effects of whatever congenital issue there might be. So there is vertebral malformations present at birth. These can be fused or malformed. Neuromuscular factors, this is another important issue. And we're not going to go into anesthesia for neuromuscular disorders today. It's a whole topic on its own that we will get to. But neuromuscular scoliosis arises from conditions like cerebral palsy, muscular dystrophy, the Duchenne's, etc. Degenerative changes. This is most likely age-related. This happens in the elderly, and that won't be covered today. And then don't forget trauma-induced scoliosis. So trauma, especially pediatric trauma, is incredibly common, unfortunately, in South Africa. And then you also need to be aware of some other factors. It can be arteriovenous malformations, there can be spinal cord tumors, etc. So we're going to go through investigations and a history relative to all of these conditions. But then when we jump into the real meat of this talk, guys, we're not going to focus on those other conditions. We're going to go through a proper idiopathic adolescent scoliosis. So moving forward, the next thing that is critically important is what is called the Cobb angle, okay? And this is a measurement of the severity of the scoliosis. So as we look at the Cobb angle, it essentially can only be measured by using an AP or PA, chest x-ray, anterior posterior or posterior anterior. And essentially one looks at where the spinal column and finds the first vertebra that is angled and the bottom vertebra that is angled, and one draws lines, and where those lines intersect, one measures the angle between those vertebrae. So basically, if I sort of just show it to you with my hands here, if you imagine that I would have a normal spine like this, okay, and then a scoliosis is going to curve outwards like that, and then curve. So that's like an S shape. Okay, so if we put it onto a piece of paper for you rather, I think that'll make it much easier. So a normal spinal cord will obviously be like this with your vertebra, very, very simple. That's a normal spinal cord like that, okay? So now, obviously a scoliosis is this S shape. So it comes down, you have a vertebra, and then what happens is you start to get this angulation of the vertebra, and it goes out, and it forms a S shape like this, and that is a scoliosis there. So what the Cobb angle does is it measures the angle, okay, parallel to the top vertebra and then to the bottom vertebra like that, okay? And this over here is the Cobb's angle, okay? So if you look there, all right, we've got normal spine, then it starts to angulate like this. You draw a line, okay, and you measure the angle. And the greater that angle, the worse the scoliosis is. So the Cobb angle essentially indicates a diagnosis. So a Cobb angle of more than 10 degrees is a scoliosis. Angles below this are considered normal. Then when the Cobb angle increases, mild is 10 to 25 degrees, moderate 25 to 40 degrees, or severe greater than 40 degrees. Surgery is needed if the Cobb angle is more than 40 degrees, if there are systemic side effects or complications of the scoliosis, and if there is a more than 5 to 10 degree increase in the angle over 6 to 12 months. We also use the Cobb angle when we look at the severity of the condition and what side effects or complications we are expecting. So what that means is I say greater than 60 degree Cobb angle, you need to have a high suspicion for pulmonary hypertension. A Cobb angle greater than 90 degrees is you need to have a mandatory echo and ECG, and pulmonary hypertension is very likely. And when the Cobb angle is above 100 degrees, pulmonary hypertension is basically guaranteed. So you need to know about the Cobb angle, you need to know how to measure it, and how it affects your understanding of the severity of this condition. What preoperative investigations are we going to be doing and why? Well, as I've said, number one, in terms of imaging, we need to do spinal x-rays, PA, and lateral. This will help us measure the severity as well as look at the lung fields, the size of the heart, and whether there is any evidence of pulmonary dysfunction and right ventricular hypertrophy. Pulmonary hypertension, excuse me. You can do an MRI to check if the spinal cord itself is abnormal, especially in congenital scoliosis, as well as neuromuscular disorders, tumors, AV malformations, and trauma. This ensures that there's no underlying neurological issues that are missed. We can also do a CT scan for complex anatomy, and that gives us a detailed 3D imaging of the vertebral anatomy. In terms of full investigations, a full blood count is mandatory. I think a renal function test is mandatory. This is major surgery, as well as a coagulation profile, and a cross-match must be done. And if there is any evidence clinically or on the imaging of pulmonary hypertension, then a room air blood gas, arterial blood gas, must be done to check if there is hypoxia or any retention of carbon dioxide. This, if that's present, that automatically increases the child's risk and means that they might need post-op ventilation, that you might want to put in a transesophageal echo probe, and they would definitely need ICU post-op. Then in terms of our next step, managing these children, we need to talk about preoperative patient counseling and consent. So remember that consent here has to be informed as always, okay? And this is surgery that can be life-changing, it can be 100% curative. However, it's major surgery with a lot of risks that we're going to go through and learn about today. So we need to discuss with the patient and their parents at an age-appropriate level to understand that there is about a 1% risk of neurological injury and about a 0.1% chance of rare post-operative visual loss. The communication with the children must be age-appropriate, and in South Africa or wherever you're from, in India, China, etc., there are language and cultural differences. Blood transfusion discussions must always be had because remember, there's a very, very high likelihood that the child is going to need to be transfused, and we're going to discuss the strategies to prevent and mitigate that risk. And then there has to be shared decision making between the patient, the parents, and the surgical and the multidisciplinary team. So when we look at preoperative blood conservation strategies, give me 1 second. This hasn't turned out as nicely as I would like it to. So the issue of consent is really important, guys. And it's just something that you need to just think about and take into consideration and, involve a multidisciplinary team and just, answer as many questions as the patient or the parents might have. So as we then move to the preoperative considerations about blood conservation, we'll just have a quick look here at the Cobb angle. So just to show you again, the neutral vertebra, you then measure a line from the end vertebra and then again from the bottom end vertebra, and you then measure the Cobb angle. And then this is an echocardiogram. Remember I said to you, importantly, that the Cobb angle more than 60 degrees means an increased risk of pulmonary hypertension. A Cobb angle more than 90 degrees means very high risk for pulmonary hypertension, and a Cobb angle more than 100 degrees means it's basically guaranteed. So this is an echocardiogram, TE, of the showing a dilated RA blowing into the LA, and then you see a very large D sign, of the right ventricle, and you get RV, right ventricular pulmonary artery decoupling or uncoupling. So that's just things to look out for and important considerations when you're looking at the Cobb angle. The episode is not over. There is much more content from Dr. Tristan in the tutorial. Please go to patreon.com and search for Dr. Tristan Anesthesia Tutorials. and choose a subscription option that best suits your needs to get access to the full episodes, weekly AMAs, and show notes, and so much more. Thanks so much for your support. Patreon.com/Dr. Tristan Anesthesia Tutorials.